everyone. Myself, Dr. Kartik Bhosale, welcomes you all in this topic. Let's get updated on hypertension. So, as per WHO, nearly 63% of total deaths in India are due to non-communicable diseases, of which 27% are attributable to the cardiovascular diseases, which affects 45% people in age of 40 to 69 age group. So, almost 50% of the deaths are due to cardiovascular diseases, those who are more than 40 years of age. Raised blood pressure is among the most important risk factor of cardiovascular diseases. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and poor follow-up. So in India, the prevalence has gone up to over 30 years to 38% in men and 32% in women, from 29% and 28% respectively. So this is huge rise. Despite that, nearly half of the people, or 51% of men and 41% of women with hypertension, were unaware of this condition. Additionally, over 62% of men and more than 53% of women living with hypertension did not get any treatment. Medication was used to control blood pressure in fewer than 1 in 5 men and 1 in 4 women with hypertension worldwide. So as the prevalence is increasing, but the awareness, the treatment, and the control of blood pressure is very low, according to the latest WHO report, which was published in one of the renowned journals, Lancet. The International Society of Hypertension has released the ISS 2020 Global Hypertension Practice Guideline. The inclusion of optimal and essential treatment paradigms address the issue that in resource poor settings. So our country also falls in a resource poor location. Optimal care refers to evidence-based standard of care, and whereas essential standards refer to minimum standard of care to allow specification of essential standard of care for low resource settings. The AHA, that is American Heart Association, has released a scientific statement in 2021, offering new guidance for the management of stage 1 hypertension among patients with low atherosclerotic cardiovascular disease risk. Among low risk adult, that is no ASCVD, or when 10-year risk of CVD is less than 10%, with stage 1 hypertension, that is blood pressure of systolic blood pressure of 130 to 139 and diastolic blood pressure of 80 to 89 of millimeters of mercury, management starts with the non-pharmacological therapy. If the blood pressure remains uncontrolled at the end of 3 to 6 months, then we have to consider starting pharmacological therapy. So for even this high normal stage or stage 1 hypertension, we have to go for non-pharmacological management like diet and lifestyle modification. If still it is not controlled within 3 to 6 months, then we have to consider for the pharmacological treatment. ARDS, that is acute respiratory distress syndrome, is a potentially fatal condition involving lung damage, and experts often associate it with severe COVID-19 infection. As we have all seen the second wave of COVID and the severity of this disease. A recent study which appears in Journal of American College of Cardiology reports that metoprolol can reduce lung inflammation and improve respiratory function in people with COVID-19 induced ARDS, which was published in last year only. So this drug can be used in patients who are recovering from the ARDS. Then lowering systolic blood pressure targets down to the 110 to less than 130 millimeters of mercury range substantially reduced adverse events in step randomized trial, affirming the sprint finding for an older Chinese population. So among some 8,500 patients ages between 60 to 80 in China, the intensive target trimmed 26% of the composite severity, finding from now a second major trial supporting a lower target could unite the guidelines, which even among US professional societies ranges from threshold of 130 to 150 millimeters of mercury. So this STEP trial, which was performed in Chinese population, this also supported the findings of SPRING trial that lowering the blood pressure below 130 millimeters of mercury will helpful in reducing cardiovascular risk. So it's not the 140, it's a 130, less than 130 is the target for the treatment of hypertension. With regard to prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, the 2018 European guidelines on the management of arterial hypertension recommended that The diagnosis of hypertension should not only be dependent on the office blood pressure measurement, but also an out of office measurements such as ABPM or home blood pressure monitoring. 24-hour and nighttime BP measurements were associated with greater risk of mortality and composite of CV outcome. Thus, they may be considered as the most relevant measurement for estimating CV risk. For every 20/10 systolic 20 blood pressure and diastolic blood pressure of 10 millimeters of mercury increment of BP measured at night, the risk of mortality increases by 23% and risk of cardiovascular events by 36%. So it is very important to treat the blood pressure and to treat it at optimum level, because even 20 of systolic and 10 of diastolic can increase the risk of mortality by 23%. So it is a huge risk, and cardiovascular risk by 36%. Although it's a relative risk, but it's a significant risk that is increased because of this risk factor. Most patients with hypertension requires lifelong medical therapy to achieve optimal BP control. The 2018 European guidelines equally recommended 5 classes of antihypertensive drugs. Considering high non-adherence treatment, the importance of combination treatment is particularly highlighted to improve adherence to therapy and BP control. Therefore, the 2018 European guidelines recommend, especially in the context of lower BP targets, to start antihypertensive therapy with an initial dual fixed combination of ACE inhibitor or ARB with calcium channel blocker or diuretic. So current guidelines recommend combination treatment over a single drug treatment to increase the compliance and also to have a better control of blood pressure. So these are the combination of drugs which are supposedly to be started, because different trial has shown the superiority of this combination of drug compared to the single drug. Since early July 2018, products containing valsartan have been recalled worldwide. The reason is the detection of known carcinogen, namely N-nitrosodimethylamine, that is NDMA, which can be found in condesartan, irbesartan, losartan, olmesartan, and valsartan. NDMA has been classified by the WHO International Agency for Research on Cancer to be carcinogenic in humans. So if 1 lakh patient would have received NDMA contaminated valsartan from Jianghuai, this is manufacturing site where the highest level of contaminants were found, every day for 6 years in the highest dose, it could result in 22 additional liver cancers over the lifetime of these patients. The presence of NDMA in these drugs could lead to 8 additional cancer cases in 1 lakh patients if they had taken the highest daily dose over 4 years. So valsartan recall accompanied by a significant increase in the rate of emergency department visits of +6%. So this carcinogenic compound has been found in a valsartan from which was manufactured in this area. So this warning has been released to recall the valsartan. The HYGEA study represents the largest study that tested nighttime antihypertensive treatment. In this trial, chronotherapy was associated with significant reduction in endpoints, including deaths. The HYGEA chronotherapy trial tested whether nighttime therapy in comparison to usually upon awakening hypertension therapy experts a favorable risk reduction. The largest study included a total of 19,084 hypertensive patients. During an average follow-up of 6.3 years, 1,752 participants experienced a primary CV outcome. And ambulatory BP measurements was performed for 48 hours to collect data on how BP differed during the sleep. The RR reduction for CV events was significantly improved for nighttime treatment when compared to the awakening treatment. So this study, that is HYGEA study, has showed that nighttime treatment instead of early morning antihypertensive treatment, nighttime BP lowering drugs has significantly reduced the CV events compared to the daytime treatment. Apart from starting combination therapy, starting therapy with drugs mainly at the night might help the patient. Thank you.